So we've got another video to show. We'll just bring that one up. And this is really just showing you a different technique or a different way of reconstructing the arch in the Norwood. And it really achieves exactly the same thing, because it's got exactly those same priorities, which are to obviously make sure you've got a nice unobstructed arch, but also very importantly making sure that you've augmented the arch proximally, so that you're not kinking or twisting that tiny little aorta, which is going to be certainly in the setting of aortic atresia, it's going to be your source of coronary blood flow. So this is just showing a different way of achieving the same thing. It's a way we sort of designed when I was in Birmingham, when we found it quite a useful, reproducible way of reconstructing the arch in the Norwood pretty well, regardless of what their precise morphology is case by case. So you can adapt it to most of these cases. And I think it's useful to you maybe to have the option of two techniques at hand if you want to sort of try them. And the great advantage, of course, of the models is that you can try these out on the models and in the simulations and kind of decide which ones you're comfortable with. So here we are, exactly the same sort of anatomy again, and we'll show you this kind of different technique. But again, it's I say, really important is this long, as you well know, particularly in aortic atresia, you often have a very long and very small ascending aorta, and of course the coronary blood flow is completely dependent on the blood flow getting in down to the coronaries. And so the idea behind this technique is to really try and augment that ascending aorta as much as you possibly can, as low as possible, and make sure that you maximize the sort of coronary inflow, if you like, from the reconstructed arch. And it's really very similar to what you achieve with what Asami was showing you by making a little V incision here, so that you make an incision as low as possible down into this little aortic root. So I'm always struck when you see the angios of these patients when they're older, that the little ascending aortic root often really doesn't grow very much, and it stays very, very small. So if you've got the opportunity to really enlarge it as a neonate, then I think it seems to make sense to maximize your coronary inflow. And I think hopefully what we'll show you is by putting the patch in this way, hopefully it maintains that relationship that exists, in the untouched heart between the pulmonary artery and the aorta, so you don't get any distortion or twisting or kinking of that rather small and fragile ascending aorta. So again, as we showed you, again, this is Pam's beautiful video that she's put together from us from our demonstration, and here we are. Remember, these are the principles, the dogma of the Norwood. You've got to create an unobstructed arch. You need to make sure you've got unobstructed return of blood from the lungs. So you have to make sure you take out whole atrial septum, and then you have to make a balanced circulation. So you can do that any way you choose, either with a RV to PA conduit type Sarno shunt or with the BT shunt. But I say today, and for this course, we're really focusing on the arch reconstruction. So we kind of call it the augmentation-implantation technique, if you like. So you see the patch augmenting the whole arch exactly as you've seen in the previous technique, but perhaps hold on, but you see how I'm going to just run the video back a second, and then if you focus on the sort of here, you can see how hopefully it maintains the relationship between the ascending aorta and the pulmonary artery root, because they're such different sizes that the torsions and pressures on them are very different, obviously, when they're pressurized and filled with blood. So here's our anatomy, and the start of the technique, exactly the same, of course, is to ligate your duct. Duct's a strange creature. Yeah, it's huge usually in these patients because they've been deliberately maintained on prostaglandin, but it's very soft, and it's really all of its strength comes from the adventitia. So it's very important to try not to interfere with the adventitia in the first part of the surgery while you're mobilizing things. But then once you're on bypass, you can ligate the duct safely and it's out of your way. So the first thing we do is transect the main pulmonary artery, exactly as Sami was showing you. And you haven't got much choice really in where you're going to transect it, because there's not much room between the top of the sinotubular junction and where the branch come off. So you just sort of come straight through there. And I think the problem is, particularly for the right pulmonary artery, your transection line is always quite close to the origin of the right pulmonary artery, but it's very difficult really to avoid that, because it's more important to make sure, I think, you've got enough height on your neopulmonary route. So you're left with this defect in the central pulmonary arteries, and you have to decide how you're going to manage that. And it can really be managed in all sorts of ways, really. I know it's quite common that people just close it directly together, and that's a reasonable thing to do, because whatever you do, it's a bit frustrating. There's almost too much tissue in there, and the tissue you want isn't quite in the right place, because you've got lots of tissue at the top here where the duct is originating, and not enough tissue here at the origins of the branch pulmonary arteries. And obviously really important to make sure you don't get narrowings here in the origins of the left and right pulmonary artery. So you can just close this directly, and you can close it either horizontally like this, or you can kind of close it side to side, almost like a vertical suture line. And I must say, over the years, I've tried all these things, and there always seems to be a risk that you get some origin stenosis, particularly of the left pulmonary artery. And so usually what I do is put a little patch in here, and the patch, isn't because you need more tissue, because you don't, but the patch is really trying to augment these origins of the branch pulmonary artery. So it really doesn't have to be a very big patch at all, but just by sitting in that spot where there's a risk of narrowing down the origins of the branch pulmonary arteries, I've just found that this is a more kind of secure way of making sure the branch pulmonary arteries stay nice and wide open for the future. And you can see that actually you don't need to patch or augment this at all. So you can really bunch your sutures together here, because the patch is doing its job here at the origins of the branch pulmonary arteries. And you can actually sort of plicate this rather baggy material here at the top of the duct all back together. So we'll just let that run, and it takes you to complete that patch. And you can do this if you have time on the models tomorrow, just to practice. But you can see what I'm trying to show is that hopefully holds the origins of the branch pulmonary arteries nice and open. So now we move properly to the arch, the reconstruction. So the whole duct has to come out. Yeah, it's horrible material. It's soft. It looks like sort of soft cheese on the inside. So you really have to work hard to make sure you take all the ductal tissue out and you get back to healthy looking normal aortic tissue. So all of this ugly ductal tissue comes out. Then you transect the descending aorta and take out the site of the coarctation and the isthmus. Almost always there's a coarctation ridge there to see, and it's always narrowed here. So it's best just to cut it out and cut out the isthmus, and you're left hopefully back to some nice healthy tissue. And this is exactly as you were seeing with Asami. So I do this having reached a nice cold 18 degrees and the circulatory rest for a few minutes. Just cut out the duct. Then you have a little side biting clamp on the descending aorta, and you can spend a few minutes really mobilizing and getting some length on the descending aorta. Usually you don't need to sacrifice any of the intercostal arteries because they're quite elastic, and you can mobilize the aorta around them and give it some stretch and elasticity without sacrificing the intercostals. And then you've got this nice length of descending aorta free. Your clamp can go nice and low down, and then you can run back onto head and neck perfusion for the rest of your reconstruction. So I cut, an incision down into the descending aorta, and you can equally make the interdigitating incision at the back of the aorta if you want to as well, if it feels big enough. But this is really important, yeah, and this is this long incision all the way down the ascending aorta. Let me run it back again. So using, with a pair of reversed angled scissors, you really augment this proximal component of the arch all the way along its inner curvature. So really want to have a good view of this tissue, make sure you can see exactly where you're headed, but you want to take this incision right down, yeah, below the level of where the neopulmonary artery or the neoaorta is transected here, the pulmonary artery root. So your incision has to come right down as close as you can down into the aortic root, almost, as far as you dare, all the way down here. But obviously not so far down you get close to the coronaries. But you can see how low down that comes. Right down, and very important to stay on the facing side, on the inner curvature of the arch for your patch reconstruction. So the first thing, exactly as you've seen done already today, is reconstructing the back wall of the descending aorta. So joining that into the underside of the arch, quite similar to what you were doing today with the arch reconstructions. But the most important thing, is A, to be sure you've got rid of all the coarctation and the ductal tissue, and secondly, to really make a long, wide anastomosis at the back of the arch, because that's your native tissue-to-tissue anastomosis where you're going to get your growth. So a sort of extended end-to-end joining up, exactly as you've seen with the Sami's demonstration, to reconstruct the back wall of the arch, a really nice broad incision. You say if you don't feel the descending aorta is big enough, you can make that interdigitating incision in the back of the descending aorta as well. But it's really bringing those almost lateral walls of the descending aorta up, yeah, on both sides. So you've got a really nice long anastomosis, real width to that reconstructed aorta, and hopefully no residual ductal tissue left behind. Yeah, so just trying to show you there, yeah, a nice long anastomosis. You cut down the descending aorta to take all the tension off everything. And then here's the patch that I would use for this sort of technique. So it's a kind of long oval shaped patch. If anything, make it longer than you think you need, because you can always trim it as you go. And in terms of its diameter, I would say, what I do is I choose 1.5 times the diameter of the descending aorta, because you're always going to lose some patch because of your suture line. It's going to steal a bit of the edge of the patch. And that you want the patch to bow forward, so you create a sort of cylindrical or circular cross-sectional shape to the reconstructed aorta. And usually, as I say, a sort of guide of 1.5 times the diameter of the descending aorta is what I would usually use. So it starts, for me, always the same way, right down at the nadir, at the lowest point of the descending aorta, and I try and keep the suture line, forehand as much as possible. So it goes from, if you look at the apex here, it goes just on the lateral side of the apex and through the patch, then next suture at the apex and through the patch, and then third suture my side of the apex and through the patch. And you keep the stitches spread apart so that you're putting lots of width of patch into that descending aorta, so that you're really trying to augment the width of the aorta rather than the length of it. So you try to put lots of width of patch in here, and once you've got those first sutures down, you can parachute the patch down, and then you just continue with the same needle, yeah, and start coming up. So you can stay forehand the whole way, and just keep bringing this up into the underside of the arch. So you come to where you've met your first stitch. You can often cut off those little corners, just as Tommy showed you, and then you lock it from. And also always aware that the three-way join is where you may potentially get some bleeding. So you may over your suture line with an extra throw of your suture to really try and bring that little two-way join together. Then I just carry on along the underside of the arch, along the lesser curve, bringing this patch around. Usually once you get sort of as far as the brachiocephalic artery, you can stop. Then you go back to where you started, right down at the back of at the bottom of the nadir, the descending aorta, and now you're coming up the lateral side. Again, it's all forehand all the way. And again, you're coming round and you're going to meet the suture that you use to rejoin the back of the arch. Again, join, lock it all together, and then carry on coming forward with the patch. And as you come around the arch now, the patch is taking on its natural sort of shape of the reconstructed aorta, and hopefully a nice sort of cylindrical shape and a Roman-shaped kind of arch. Again, if you're lucky enough to have pulmonary homograft, it's usually the nicest material because it's so soft, it naturally adapts to the curvature of the aorta. If you don't have it, I would recommend using, glyceraldehyde preserved autologous pericardium, which is slightly stiffer, but it's still pretty nice to use. So here you can see the patch there going all the way down to augment the aortic arch. And then you just carry on, and we're going to bring that patch all the way down the ascending aorta, right down into the aortic root. And I think, if anything, you want to make your patch longer than you think you need, because you can always trim it. If anything, it was pretty well close to being what we needed in this example. But here, as it comes right down into the root, you can see what you're hoping to do is augmenting, that width, if you like, the actual volume of the little ascending root. And you can usually, get exactly this sort of view. It is very good, I think, sort of simulation of what you see in real life. And you can follow your sutures carefully as they come out to into that little aortic root. And then you bring the patch right around the lowest point and start coming up the inner curvature on the sort of lateral side of the aorta. There you are. So you see the patch all the way down. You can see, you want to see, you can drop your probe right down into the little ascending aortic root. And then this is the sort of final part now of the reconstruction. So we before completing the suture line, you leave yourself a little opening here, and the neoaorta, as it were, the pulmonary root, is going to go into the patch in a separate incision. So you make a separate incision into the belly of the patch and make a nice big broad opening. So a really big opening, a separate opening into the patch, and actually cut out a little bit of the patch material. So you've got a big oval opening. The opening should extend out beyond the left carotid artery. So it takes the neoaorta back. So it really implants into the underside of the aorta. And I think the attraction of this is because you've got the patch now in the both sort of anterior and superior components of the arch, is that you're allowing the neoaortic root to sit in its sort of natural orientation without being pulled up too high. It doesn't have to come up right up into the arch, it's coming up into the patch. And hopefully this holds its sort of natural orientation. And again, just now coming on the back wall. I think, one potential risk with this sort of technique is, well, you're making an incision into the patch, which can't necessarily grow. But all I can say is it doesn't seem to have become a problem. You don't seem to come back with these patients. We've got patients who are adults now who had this technique performed, and it's already about a 12 or 14 millimeter opening that you make in the homograft patch, just because that is the size of the PA often in these neonates who've been on Prostin. And so it seems to be a very large opening, and we haven't seen narrowing occurring here as it stretches up and grows as the child grows into an adult. So it does seem to actually grow and not be an issue. So you then bring this neoaortic root into your reconstructed patch. And again, hopefully it's holding it in its natural position. So hopefully it gives you a nice competent neoaortic valve as well, because you're not distorting or twisting the root from its natural position. And once you've finished that, all we're left with is this little defect. So we hadn't quite finished that original suture line. and it's quite, you can have a little look in through that opening to make sure you're happy, and then close it all up. And then in a moment, hopefully we'll see the finished result. And I think it's achieving exactly what you're achieving with the other method. It's just a different way of doing it. I quite like the way that it sort of maintains the natural relationship between the aorta and the Neoaortic, if you like, the DKS, and hopefully prevents that risk of killing that critical little ascending aortic route, and making sure you've got good pulmonary blood flow. Coronary blood flow, because that's your key. And there's the sort of reconstructed arch on the side, hopefully plenty of space for your bronchus and left pulmonary artery. So there we go, 2 different techniques of doing the same thing. And hopefully you'll have the opportunity tomorrow to try both those techniques and get a feel for their sort of which ones you're most kind of comfortable with. So any thoughts, any questions?
I have a question.
Yeah, go ahead.
Between both techniques, is there any hemodynamic studies or MRIs or something that can help us to know which technique is better than other, or it's just a surgeon's point of view?
No, I wish. No, it is. It's really. There have never been any real kind of directly comparable or studies to look at the 2 techniques side by side. So we can't say that one is better than the other. I do think the interdigitating technique has really been shown in terms of the distal aortic arch, to be very effective in minimizing the risk of getting recoarctation in terms of the back of the arch, the posterior segment.
What do you mean by interdigitating? I'm sorry.
Well, it's making that extra incision into the descending aorta at the back of it, the most posterior part of the descending aorta. Before you reconnect them, you make an incision into the back of it, so that you're kind of interdigitating the arch into the back of the descending aorta. So it splays the descending aorta out a bit and gives you a longer anastomotic line.
So is that I didn't get that part. So in your technique, you open the posterior, and then the other technique, Dr. Honyo,
No, both techniques you can interdigitate. The only difference between the techniques is the actual DKS component, how you actually join the proximal aorta and the Neoaorta, the pulmonary artery route together. That's the only difference.
But like in quotation, we normally open it a little bit anterior and lateral, right? Extended, so we can make the descending aorta a little bit bigger. In the Norwood, will be the same, or will be more anterior or more posterior?
It's the same idea, but it's more directly a midline sort of incision in the back posteriorly. But it's quite similar to what you could do in a cartilation repair.
Okay.
Yeah, the same idea, but in a typical hypoplast, you have a very small aortic arch, so your ratio of native versus patch will be less. Right? So that means it's more important to get it right at the distal anastomosis compared to simpler coarctation.
Thank you very much.
Can I ask a question regarding re-establishing pulmonary blood flow? What do you prefer to use?
For pulmonary blood flow, well, we prefer here to use a Sarno conduit, an RV to PA conduit, and we take to the right side. The debate has gone on for 10 years, if not 20 years, of which is the best thing to use. And people still use what was originally described, Norwood, and people have excellent results with it. So we all look at the results of the single ventricle reconstruction trial that did a randomized study, the two techniques side by side. Although the RV to PA conduit came out initially as having a survival benefit, as you follow these patients up longer, that benefit gets less and less, and the two groups are really standing now almost identically side by side in terms of their survival out at sort of 7-8 years. So truly you can choose whichever technique you feel more comfortable with, because I don't think we still could tell you that one technique is genuinely better than the other. I think the suggestion is the RV to PA conduit certainly gives you a slightly more stable circulation in the first few days post-operatively. So, you know, if you're, particularly in terms of your ITU management, it may be a bit more straightforward. But, you know, you genuinely can choose, I think, which you're most comfortable with. What would you say, Osami?
Yeah, well, see, when we switched to Sano shunt from BT shunt, I would say 7-8 years ago, I think. And then once we get used to the Sano shunt, those patients are quite stable. It's not like you know, BT shunt and in parallel circulation. They're quite stable and then move very quickly. So hemodynamically, we see the difference. Single ventricle trials, long-term outcome is a bit depressing. That doesn't seem to have long-term benefit, but we like Sano shunt, yeah. What do you think, Nabio?
I like the idea of the RV to PA conduit, yeah. I guess it's a nicer night for the surgeon if they don't have a BT shunt, but that shouldn't dictate the decision. But do some people take it to the left, the RV to PA conduit, rather than the right? I know you take it to the right because it makes it a bit easier for the second stage.
It was first described, you know, take it to the left, because that does seem more sort of iterative where it should belong. But I think it's I'm not sure if we could say we've surveyed you know, the major centres around the world to know which way people are going. I know a lot of people take it to the right these days, so I'm not sure whether whether left or right has come to be the predominant form, but it's certainly done in both directions. You can take your pick what you like. I think, as I say, I like it to the right because it makes it accessible for your second stage so much more easily. And if you've got any stenosis related to the shunt insertion, you can get to it very easily.
Yeah, from my learning curve point of view, it's a night and day. When I switch to the right side, it's really easy to it's easier to connect, because you know the left side obviously with a reconstructed arch is difficult to see and less likely to distort the LPA. Which is, you know, it's really painful if you have a bad LPA to deal with in the second stage.
Yeah, exactly.
And then make second stage much safer and more predictable. I think I'm sure there's a great way to do it to the left. But in my limited experience with the left side Sano, I think it made a huge difference when I changed it.
And can I ask for the RV to PA conduit on Dr. Barron, your technique? When do you make the ventriculotomy incision? And the second question is, do you both use the dunk technique?
Yeah, so timing-wise, so in terms of the sort of sequence of the surgery, I do the RV to PA conduit at the beginning, so while you're cooling down. So just on the beating heart, you can connect the distal conduit to the right pulmonary artery, and then if there's aortic stenosis, then you can put a cross clamp on, give cardioplegia, and then do a little right ventriculotomy and sew in the conduit. And you can do all that while you're cooling down, waiting to start your arch reconstruction. If there's aortic atresia, you can actually make the ventriculotomy without having to put a cross clamp on, because there's no risk of any air getting into the into the aorta. But of course, that means you're having to do the connection with the heart beating. So you can choose what you prefer. I don't dunk it. I just use a standard Gore-Tex and sew the Gore-Tex, onto the surface, or they're full thickness bites, but the conduit sits on the surface a bit like the cobra head sort of shape of a coronary artery, a saphenous vein graft on the aorta, the same sort of style of anastomosis. But I think, Osama, you tend to dunk it, don't you?
Yeah, I really like that dunk technique. It's well, it's somewhat, it's sort of almost like a surgeon's failure. We're giving up the beauty of anastomosis, but there's no anastomosis in the proximal end, so there's almost no way you can get that gut stenosed. And then so as shown in the video, I usually make a right ventriculotomy incision just before closing off the DKS part, and then dunk it, and then do the proximal part area, and when we're rewarming, I just connect distal anastomosis.
Thank you very much.
So, I mean, because this week we're concentrating on arch reconstruction, we haven't really shown you the sino conduit, but these models are beautiful. You can put a little sino shunt into them as well, if you like, as part of your whole kind of Norwood reconstruction.
I had a small question, David. So I was reading Dr. Brown's papers back in the day when I was a resident. He used to reconstruct his whole arch without any patch augmentation.
Yeah.
Do you still do that in some cases, or?
No, most of it, we went away for it. So yeah, in the 90s, Bill Braun described trying to reconstruct the arch without using any artificial material at all. Using the extra material you get from having such a big, pulmonary artery route, but it was abandoned quite soon because it just puts too much tension on the arch. You do the transverse arch and the ascending aorta are often so small that there's not enough tissue there, and it just puts too much tension on everything, and you get a lot of stenoses or recoarctation or distortion of the arch. So actually, way back in the 90s, you abandoned that. But it's interesting. It's always maintained some interest, particularly I think in places where you can't get hold of homograft material, in trying to find ways of reconstructing without it. And I think people still have looked at trying to do the Norwood reconstruction without artificial material. But I think unless you're lucky enough to have cases where they've really got quite a good sized ascending aorta and transverse arch, then it's just not reliable to try and do the reconstruction without any patch material. So we completely abandoned it way back. Yeah.
Dr. Honjo, I might be wrong, but a couple of years ago I saw a talk by Dr. Sano who was talking about a similar type of technique, reimplanting the pulmonary trunk to the aortic arch. Are you aware of it?
Well, so Dr. Sano was the student of Dr. Brown, so.
I see. Small world.
There's only a couple of major schools in the world. So.
Yeah, from his presentation, he seemed to say he's got pretty good results from it.
Yeah, I think Dr. Sano's major series, I think he did most of the reconstruction without any materials, but I think he has some problem with the left coronary artery as well, because the window underneath the aortic arch is really tight.
Yeah.
I think overall, as long as you have a good material for the patch, I think it's safer to patch it properly.
And just a bit of a philosophical question. Do you think we'll be doing this in 20 years' time? Or how do you think it will change?
What do you mean? You mean our retirement plan, or?
No.
I'll be on a beach somewhere, Nabil, thanks, in 20 years' time, I hope.
I'll FaceTime you.
Right, yeah, it's difficult to imagine any kind of dramatic difference, or how we can, use hypoplastic left heart any differently. I suspect we'll still be doing some sort of Norwood type reconstruction in 20 years' time. Whether we'll have found a better way of balancing the circulation and of finding pulmonary blood flow in a sort of different way, but I can't at the moment see us really doing anything different. We've the hybrid hasn't come and gone, but the hybrid hasn't been has by no means been an answer, and it's still used very selectively. So I don't think that's necessarily going to be our answer, and unless we can find a way to magically start to grow myocardium and create new ventricles, I think we're going to be using the Norwood reconstruction for the foreseeable future.
I agree. The patch material may change in 20 years, right?
Yeah.
One drawback of using homograft is obviously the sensitization, because knowing that some of those patients eventually need a transplant. So it makes sense to try to develop some biomaterial or the material that does not sensitize the patient and also viable in the long term.
Yeah. Okay. We're going to wrap up, everybody. Thank you very much for your time today. So we'll meet up again tomorrow, same time.
6:50.
6:50
Yes.
Eastern Standard Time.
And then ask you to fill in the assessment too.
And then if you can fill in your assessments of the procedures you've done today, that'll be very helpful. And then tomorrow we're going to do, as I say, focus on doing the arch reconstruction in the Norwood. So you can try both those techniques. So we'll see you tomorrow. Have a good day.